Ladies and gentlemen, welcome to the future. My name is Zach Gardner. I'm the chief architect at Keyhole Software, so they tell me. And I went on a little bit of a journey last year. I scoured the internet to find people that knew a thing or two about generative AI. It was an area that I was legitimately interested in learning more about. And rather than going at it alone, trying to cross the Rubicon on a one-man kayak, I decided to invite some friends to come along with me on this journey. Today, with you, is John Travis, the principal at JFT LLC. John's was a long time Cerner associate. You have a really deep experience in a lot of different things. So thank you very much for joining me today, John.
My pleasure, Zach.
So why don't you give the audience a little bit of a background? Where'd you grow up? Do you remember the first, like your favorite Christmas present as a kid? Where did your professional career take you, and how did you land into becoming the principal at JFT LLC? Let's start there.
Yeah, I grew up in Topeka. So as they say, Topeka is a great place to visit, but you wouldn't want to live there. And I apologize to those who live there and love it. Fine hometown, though. I went to Kansas State for my undergrad. And I started out my career in public accounting for, at that time, Ernst & Winning, now it's Ernst & Young. And I got involved in healthcare audit right off the bat in the very first year that Medicare created the DRG payment system for hospitals. So a lot of learning, not learning by doing. I encountered things I never imagined they didn't tell us about in business school as to how healthcare services are paid for, which have nothing to do with how they're priced. So a three-party third payer market that really influenced how those things are paid for. I left public accounting after a couple of years and went to Cerner when it was very young. This would have been in 1986. I was one of the first 200 people to be hired there. It wound up being a multi-billion-dollar enterprise by the time it was sold to Oracle about a year and a half ago. Actually, yeah, right about a year and a half ago. And when I was there, I got the chance to be in a variety of roles, but for probably half the time I was there, I led what came to be called our regulatory strategy team. And basically that group was responsible for really doing all the research and keeping up on all the federal regulatory space that impacted the use of health information technology. So everything from dealing with HIPAA for privacy and security to revenue cycle compliance, all the myriad Medicare and Medicaid requirements for billing and for claims and for dealing with transacting with the Medicare program, with the payer market around the HIPAA transaction set, and eventually dealing also with the clinical and operational compliance requirements of being a Medicare participating provider. And along the way, this thing called health IT certification came up as a requirement that we had to deal with starting in the mid to late 2000s. And that still persists to this day. And that is under the Office of the National Coordinator for Health IT. They are responsible for really trying to provide a public assurance to the market that health information technology that is recognized as certified meets certain requirements, especially around interoperability, security, and now we have artificial intelligence beginning to show up in the decision support space as a new element of certification that all HIT developers that want to have that status, that they will have to certify to by the end of this year. Now that certification is mainly used to enable hospitals, critical access hospitals, and what are called eligible clinicians, who are mostly physicians, but not all. It also includes other kinds of licensed independent practitioners, like certain kinds of therapists, nurse practitioners, other kinds of what they call mid-level professionals. to use health information technology in ways that are meaningful. And there was an old term that's been around for about 14 years called meaningful use. And that simply means that you're using health information technology that's been vetted and certified to contain specific capabilities that the federal government has enacted through regulation as requirements if you want to be fully paid under the Medicare program. If you don't use health IT that's certified, then you actually receive a reduction in your payments as a hospital, as a physician participating in the Medicare program. So it's got the attention over the years of a lot of healthcare providers, and it's pretty much a normative requirement that if you want to be credible in the market as an IT developer, you probably need to consider getting certified. So I left Cerner about a year ago, and I've had my own consultancy, as you mentioned, and it's been centered around a lot of the things that operate at the intersect of health IT and regulatory compliance.
Very cool. And that is exactly why I wanted to pick your brain on this topic. So before we get too much farther in, the disclaimer that I'm not a lawyer, but I know a few of them that they always tell me to say, though not from a real recommendation standpoint. They're just like, hey, you probably better say this. All the views and opinions expressed in this program are the views and opinions of the participants and do not reflect their employers, their trade organizations, any religious institutions they are affiliated with, any, I don't know, backpacking clubs that this is just two guys talking. We're just having a chat. We're just having a chat. That's all. So you mentioned the ONC HIT, which is a two 3-letter acronyms, kind of mashed together to make a 6-letter acronym, the Office of the National Coordinator for Healthcare Information Technology. As someone who has seen, policies and federal regulations evolve over your, very storied career, I was actually describing DRGs to someone on, I think it was Friday night, and their mind was blown. They're like, "What? That's how it actually works?" Like, yeah,
It's not a conversation starter at a party, Zach, but depends on who's at the
maybe we
party.
run in different crowds, John. I don't know.
That could be. That could be.
So I'm curious if you could talk to me about maybe what are you seeing on a federal level in terms of the balance that they're trying to strike with generative AI having such a massive potential upside, but things like hallucinations and incorrect information. What are you seeing at like a federal regulatory level in terms of how they're trying to thread that needle to make sure that we as consumers can benefit as much as possible and try to minimize the downsides?
Yeah, I think the biggest interest the federal government has, whether you're speaking of looking at patient safety interests or looking at accuracy and validity of the results of the use of the AI, is really trying to make sure that it is applied in a fair and equitable way, and that the chances for bias, and what most people think about, and it's not incorrect at all, is discriminatory bias based on factors that matter to the use case at hand. And what has most people's attention is whether or not the AI is performing in a way or was trained in a way that was representative across the intended population to which it is to be served, or the use cases to which it's to be used. So one example might be if you're using generative AI to investigate claims denials or prior authorization approvals and what it is going to be necessary to get a service authorized for payment. If that AI was trained in a way that it doesn't consider a balanced patient population that represents different age groups, different genders, different races and ethnicities, you could wind up with something that is a inappropriate response for the particular circumstance that you're trying to get the answer to, or the particular decision support factor that you're trying to use the generative AI to achieve. So a lot of the interests are very much around prevention of bias, prevention of inappropriate outcomes or inappropriate use of the AI for the population or the particular instance at hand, if it's a specific patient situation that you're trying to pursue an answer to or trying to make a decision about.
Mm-hmm. No, that's interesting. I've heard a lot of other people talking about sort of the discrimination bias. Some of it just might be unintentional. You know, like you have a sample data set that was maybe from the East Coast and then the West Coast, which is where a lot of the firms that develop these technologies are based out of. And then you apply or attempt to apply that same kind of rationale to the Midwest. And it's like, well, I mean, we have a lower cost of living, like we were talking about, you know, while we were in the green room before this, but we also have maybe access to different kinds of foods, you know, but maybe that's, especially if you're talking about like inner city of Chicago, where they have food deserts. If someone is presenting with, you know, symptoms where maybe just eating some more broccoli would help, you might not be able to appropriately say, well, just eat some more broccoli because it's like, well, I have to travel 20 miles to go get some like fresh broccoli. Physicians and clinicians that are serving patients every day in a perfect world are a little bit more in tune, you know, with their needs, with the realities of what's going on in that world. So I've always found it, you know, really interesting where we try to take the human element out of it, where we as human beings can interact with each other, but for whatever reason, people think that that's not sort of appropriate, or it's not something that's going to be feasible in a lot of these systems because they have to be designed for a massive population. Then how do you tune it to, you know, one specific location where recommendations you might give would be completely different if it was, you know, a few zip codes away? So it's interesting you brought that up. Also for social determinants of health too.
Right.
It's that's one of the areas that I think the presentation we were last saw each other at UMKC was, they mentioned social determinants of health at least 4 or 5 times. So no, that's really good. In terms of companies that are thinking about getting into generative AI, really specifically just healthcare companies, I'm curious if there's any recommendations that you have for things that maybe you see people aren't talking about, but they should, or they don't know what they don't know. You know, what would be like some like good recommendations that you have for these kind of firms?
Yeah, I think the two things, and there's two very significant regulatory authorities to the whole problem. If you're going to be a startup in healthcare interested in developing your own algorithms, whatever your use case might be. And most people tend to think clinical, but it's not limited to that. It could as easily be, as I mentioned my example earlier, propensity to pay in terms of being able to afford the healthcare you're seeking or the kinds of services and access you're seeking. So the first concern, I think, is to really understand is for what you're trying to do, are you going to face regulation as you try to go to market? And especially around if what you're doing is something that's going to play a role in a clinical environment, supporting the decision-making process, really of any kind that has to deal with patient care, you need to really understand what is the role of your AI in a clinical decision-making process. The big entity you're worried about is the Food and Drug Administration, because if you play a particular role, specifically, you're either actually driving or making the decision, or you're providing substantive guidance to a decision such that the clinician's relying on the outcome of your algorithm to inform what they should be doing, or really strongly influence what they should be doing, you may well be a medical device. And you do have to go through regulatory processes basically to get permission from the FDA to be able to go to market. So if you're not aware of those processes, you could be sadly caught in a bad situation where you progress too far and you may have actually stepped afoul in engaging. And, you know, it's an aware buyer's market out there. They probably, if you didn't know it yourself, you're those who you may attempt to market and sell to will probably remind you of that. But that's definitely something to be mindful of. And when it comes to AI, there are particular guidelines around the kind of transparency and governance the market wants to know that you're credible. What was your expert base for what you relied on in developing your algorithm? How did you train it? What kind of database did you use? How did you test it? What are you doing to establish ongoing measurement systems and governance and oversight? So there's a whole regime of trying to assure that the AI will work for its intended purpose, which needs to be clearly stated and clearly labeled. The FDA has a lot of guidance around the topic that is well worth the read for anybody who's in that situation. Now, the Office of the National Coordinator, so the FDA has an interest really in patient safety and the efficacy of the AI for the intended purpose. So they want to know it's safe to use, it does have positive outcomes for the intended purpose, and it really works for that intended purpose. ONC is not out to evaluate the efficacy of your AI. They want to know that you're being transparent to the market. So they want to know that you have clearly identified what your source attribute data is that are used as inputs. They want to know many things that the FDA does as well, but they're wanting you to tell the market about them. So again, how did you train your database? What were its input factors? And they get very much into the risk management framework that you follow to govern your AI. And how do you do ongoing monitoring and measurement of that AI as it performs in production or operational use? So their interest is going to be much more that you are being transparent, you're providing this information to your buyers, to the market. There's a manner of it contributing to the level playing field so that it is understood how it works. It's not just a black box. So if you're either you could be a large software development company like an Epic or a NextGen or Oracle Cerner, and you may be very used to this, but it's a new requirement for you, and you may not have followed all of these disciplines in your development of algorithms before. So it could be new to you, but it's also kind of opened the door that there could be startup entities, like you mentioned, that are very interested in wanting to play a role as a certified product, but only for what they call the predictive decision support interventions criterion, which is where a lot of the regulatory requirements for AI from an ONC perspective rests. And in that case, you would do well to really understand what are the transparency requirements that they are after that really govern and drive what they want to see as transparent information to the market. And that certification in that case could be a differentiator for you. So, clearly, I think that it's got a value point for a smaller company or a startup company that is trying to play a specific niche expert role of that kind.
Mm-hmm. Interesting. I mean, you talk about the transparency of like the data set. One of the considerations that I've been thinking about for how these large language models work is that as it provides output, that is actually used as input for future iterations, not even just within the context of the conversation that you're having with it, but also for future trainings of the model. So I, as an architect, have to be aware of not just things that govern us nationally, but also, potentially having patients from the EU who are then visiting our sites and then using our products, and we have to respect GDPR. So it's really interesting for GDPR versus HIPAA. Like GDPR has the right to forget, where someone can request their data be deleted from your system. And then with HIPAA, it's like, well, I got to maintain the immutability of the medical record for 6 years. Most organizations do 7, just because you throw in an extra. It's like when you have a birthday, you get like you're 7 years old, you get 8 presents. It's always because you're looking for the next birthday, so you're just like doubly sure. So I'm curious if, because of the fact that we have these large language models that have to be trained on a large amount of patients' data, if a patient requests the right to be forgotten, but I've already trained a model 6, 7, 8 9, 10 times after that, I'm not even sure if I, as like a developer, could even feasibly ensure that their data has been fully deleted. It's just, it's a real interesting paradox that we have to grapple with. Sometimes organizations just have to pick, well, who has the higher fine? I'm going to follow their recommendation and accept the fact that if I get fined by the lower one, that I'm going to, the difference is what I'm, banking on. So I'm curious for, if you have any additional things that you're looking out for. Are there any policies that are coming out, any conversations or any additional regulations that, I as a healthcare IT architect kind of need to be concerned about? Any things that I should be following that I might not be now?
You raised a great question, and I think the answer you'd get from a regulatory perspective right now, to kind of reconcile the two, between the General Data Protection Regulation and HIPAA, would be follow or at least evaluate, do you follow the de-identification standard that's part of HIPAA privacy? So I'm not an expert on the database design themselves, if it's necessary that you have identifiable data. So if the data has been de-identified, then the GDPR requirement to the de-identified form probably doesn't apply. And as long as you follow that in terms of what you use in your large language model, you're probably going to be okay. Now, you're absolutely correct. Let's say you haven't incorporated that patient's data yet, or you've been using identifiable data within your four walls of you as a regulated entity. HIPAA would know it as a covered entity. The EU has different perspectives on who is the regulated actor, but let's just say a hospital, and you're using it for your own purpose. You're not making disclosure about that identifiable form of that data. If someone comes to you and says, I want you to remove my data, not use it in that way, under the GDPR, you can't process it. You have to stop. And it's not just right to be forgotten. It's true of the right of restriction as well. You can't process the data while that restriction is active. So you have to have some way to remove the use of that patient's data in its identifiable form in any way towards this kind of a purpose. Historic use is what it was. There's a general hallmark in privacy law and regulation that says you can rely on good faith what at the time you had the permission to do, but you can't persist in that. Something that's kind of close to that is the controls that are part of what's called 42 CFR Part 2. It's behavioral health data. It's what governs substance use disorder treatment records. You can use that information for research, but you can't disclose it in any identifiable way, absent patient consent. So those kinds of controls really point towards, if at all possible, use the de-identified form of the data, and you're probably okay to use the data, even if someone says, don't process my data. You just can't further work with identifiable data and put it into any other form at that point. I think for the regulatory interest, what's going to be really interesting to see is, are there going to be more specific requirements around the quality of the data from the perspective of its historical representativeness? So by that I mean, and I think you and I both heard it when we were at the children's presentation, one factor that's very hard to control for, especially maybe for somebody building their own that's maybe an academic center like children's, your database is as it is. The historic quality of the data may never have factored into considering anything about equity. It is the data it is. And so how does that cause you effect for what you're trying to do now? So the cleanliness of the data, the representativeness of the data, the historical, potentially historical inherent bias that may be present in the data, that if you're going to use the information, you can't really design around it because it's there. And, that may lead to another area of transparency to say, this is the representative nature of the data that I used. And that could change over the course of time if I have more intentional perspective on how I design and build that database to grow in the future. Or am I at risk of perpetuating a bias present in the data set that I used because it was the best I had? And I think there's still a lot of adaptiveness that's going to go on the next few years to get by the points of, well, the quality of the data is what I had. It's the best I had to use. So a lot of the transparency, the importance of the transparency about understanding the nature and the utility of the data for your purpose as a new user is going to be important to understand.
Mm-hmm. All great points. We could talk for hours on this topic, but unfortunately, we do not have hours. If people want to learn more about you, learn more about your work, get in touch with you, where should they go? What websites should they visit? What golf courses should they frequent? Where can people find you?
Yeah, there's a good chance to find me there. Probably the best way, my email address for my business is JFT PRG LLC at yahoo.com. And you're welcome to reach out to me there. On LinkedIn, you can find me by my name. And that is also a good way to communicate with me. And I do publish an occasional blog out there on different regulatory topics, including the one we talked about today. And you are more than welcome to access those. And, perhaps there's a leave behind if there's a chance in show notes or something like that to include that information as well, Zach, if that's possible.
Oh, I know the person that edits these things, so I think we can make that happen. So,
Very
no, John,
good.
this was awesome. Such a pleasure to talk with you again. Ladies and gentlemen, hope you found this as interesting as I did. We'll catch you in the future.